All right, well, good morning, everyone. I met many of you yesterday. I'm Ross Blank from University of Michigan. I'm the co-director of the surgical ICU, where Raghavendra and I and Jessica and Steve and Kelly have worked over the years. I'm an anesthesiologist, and I take care of a lot of respiratory failure patients in the ICU and sometimes in the operating room as well. Thank you for the warm welcome to India, and thank you for everyone's excellent questions and attention to all these interesting discussions. I'm going to talk about the concept of the open lung approach, which is there are terms that are used when we talk about ARDS. People talk about lung protective ventilation, and you put 10 intensivists in a room and you say, what is lung protective ventilation? Then you get 10 different answers. Open lung approach is similar. You put 10 intensivists in a room and say, what's an open lung approach? There's not a standard, correct textbook definition of open lung approach. It's the concept that has been referred to by previous speakers of trying to keep recruitable lung open and participating in gas exchange. And there are many different strategies that have been described to achieve that goal. The ARMA trial has been referenced many times, and it's something that's really essential dogma to understand as an intensivist practicing in the 21st century. It's also really essential to understand what it showed and what was a suggestion of increased harm from the aggressive recruitment. They had other outcomes, including pneumothorax, barotrauma, death with barotrauma, instability. All of those were higher in the aggressive recruitment maneuver group. And around the same time, there was another similar trial that was trying to start enroll patients, and the IRB stopped it early because they saw the results of this ART and didn't want to be accused of having a unethical trial design. EP-VENT2 was the follow-up to transpulmonary pressure, which was done in multiple centers in North America, including Michigan, where Raghu and I and others work. Here they used the PEEP titrated by the transpulmonary pressure and compared it to another PEEP table. They used the one from the alveoli trial, which was a little bit higher than the ARMA trial, PEEP FiO2 table. And they did a big trial, 200 patients, not huge, but relatively big trial, and they made fancy measurements to set their PEEP in one group, and they empirically just used higher PEEP in the other group, and unexpectedly and unfortunately, they ended up with the exact same PEEPs in both groups. And if you have a ventilatory trial where the protocol gives you the exact same settings in both groups, do you think that showed any difference in outcomes? The answer is no. And here are the superimposed survival curves of the two groups in the EP-VENT2. And so people see this and say, well, just using empirically higher PEEP is just as good as using this fancy measurement, so maybe I don't need to do that at all. Or people who say, well, at least I'm not causing harm by using my fancy measurements, so I'm going to keep doing that because I think it gives me important information. Like many trials in critical care, it's the type of trial that doesn't change the true believers, and it doesn't recruit many new enthusiasts to the idea. So all that being said, I've showed you two big trials with negative results. Is there a role for titrated PEEP? And I would say, especially that first ART trial, routine aggressive recruitment is not indicated for all ARDS patients. Full stop. That's not how I practice. That's not how Raghu practices. Probably not how Kapil practices either. I think there has to be a role for following the data from the large trials, but also individualizing your care for your patients in a thoughtful fashion. We see patients with severe hypoxemia who may have reason to believe they have a very low chest wall compliance, for example, the morbidly obese. And I've seen them improve with ventilator management, which has rapidly improved their gas exchange so that they don't need a more invasive strategy like ECMO, which everybody wants to talk about today, but we'll talk about tomorrow. And there are many small studies, case reports, case series about this concept in the literature. This one is dear to my heart because I trained at Mass General in Boston before I went to Michigan. They, in the 2010s, early 2020s, they created a lung rescue team at their hospital specifically to be consulted for patients with respiratory failure and high BMI. And in the United States, it's not difficult to find lots of patients with respiratory failure and high BMI. It's probably more challenging in India and other parts of the world, but not impossible. They had 50 patients over about 3 years who met this criteria, this is not a randomized trial, this is just a case series, all of those patients simultaneously received an esophageal balloon, a recruitment maneuver, not as aggressive as the ART, and a decremental PEEP trial. On average, this led to these patients having a 10 centimeter of water increase in PEEP with the expected improvements in transpulmonary pressure, oxygenation, and compliance. And this case series had an 18% mortality, which is not zero, is not low, but is lower than most of the published mortality rates for patients with severe ARDS. So, interesting, not definitive. And lastly, I just want to mention, we've alluded to a few times this concept of mechanical power. Mechanical power is a little bit hard to get your hands around because it's defined differently in different studies. The concept here is that we tend to really focus on these static parameters like plateau pressure, like driving pressure between plateau and PEEP, like total PEEP. And it just doesn't seem to make complete physiologic sense that only the static parameters matter. And this comes from a paper that Gagnoni was involved in 2020. Static variables do not directly reflect the associated volume change, rate of volume expansion, or resulting strain. Increments of energy that are applied quickly are more likely to inflict tissue damage. It is self-evident that repetition of the damage caused by one tidal cycle must exacerbate it. So the idea here is focusing only on these static parameters has to be missing part of the story. And things like rate, things like flow, things like peak pressure probably come into it. So, and mathematically, if you're more mathematically or engineering inclined, one way of defining energy is the pressure volume work of a physical process, and that can be found by integrating a pressure volume curve like we have with compliance curves. The energy is the area between the pressure volume curve and the volume axis. The power is the rate of that energy transfer, so it's that integral times the respiratory rate. To make this calculation, you have to start with the equation of motion, which is in red, and then add that to your assessment. So I looked at a paper from 2021, and they had this very convoluted equation for mechanical power, which had 3 different lines involving tidal volume, PEEP, respiratory rate, 1/2 tidal volume, driving pressure, respiratory rate, another factor of tidal volume, peak minus plateau times respiratory rate. It was every respiratory variable you can imagine put into one calculation. And I was looking at this calculation trying to figure out where the heck did this come from? And why is there a 1/2 in the middle? And it's as simple as you think it should be. So when you see something which is 1/2 times one value versus another value, that is the Euclidean formula for the area of a triangle. And this comes from taking that pressure volume curve and breaking it into geometrically simple pieces and looking at the area between the curves. You can imagine the compliance going along through the middle there and adding up the areas of those rectangles and parallelograms and triangles to the left of the pressure volume curve. So that first thing, PEEP times respiratory rate, is the blue rectangle. That second thing, the 1/2 times tidal volume times delta P, is the gray triangle. And the third one, the tidal volume times the peak minus the plateau, is that white parallelogram. So if you go back to your secondary school geometry, you can understand this. What's challenging is that if this is a meaningful concept, how do we come up with a strategy which optimizes this, because there are 12 different parameters in here? So the good news is that there have been associations between the calculated power and mortality, but there also have been associations between much simpler expressions. So this was the biggest one that I could find, 2021, Costa et al. They looked at over 4,000 ARDS patients, did that really complicated calculation of mechanical power, and showed that just looking at the middle part, there were 3 components here. The middle part that has driving pressure and tidal volume and respiratory rate was the strongest association. And if you looked just independently within the parameters, the driving pressure remained the strongest predictor, and the other one which was significant was the respiratory rate. So their proposal was to simplify your mechanical power to 4 times the delta P plus the respiratory rate, because the delta P component was stronger than the respiratory rate. So that's a very quick and dirty way of looking at power, and it basically shows you that driving pressure still seems to be the main thing that we're looking after, but how often you do that driving pressure, the respiratory rate is important. And I find that really interesting because we talked a lot about how when you do lung protective ventilation, you often feel compelled to increase the respiratory rate to maintain minute ventilation. But in principle, you are subjecting the lungs to more injury every time you repeat the process of inflating them. So strategies that could simultaneously limit your driving pressure and limit your respiratory rate would be ideal. If those strategies are going to work, they're going to have to involve being as efficient as possible with your ventilation, which is going to mean working in that sweet spot of the compliance curve, not in the shunt atelectasis part of the compliance curve, not in the hyperinflation dead space part of the compliance curve. So I still think there's a lot of suggestive information here that optimizing your PEEP to improve your compliance, to improve your minute ventilation, to improve your CO2 clearance is beneficial, but it has not been prospectively verified yet. I can think of at least 2 large trials. One's called the Prevent VILI, which we're starting to enroll patients for at Michigan. One's called the DRIVE trial, which is out of Australia and Canada, I believe. We'll be addressing this in years to come, primarily looking at driving pressure. And here's just to show you, here's one recent paper looking at a specific smaller paper looking at driving pressure limiting strategy called the STAMINA trial. But like the EP-VENT2, the protocol in this trial created no difference in driving pressure between the control group and the experimental group, and there was no difference in outcomes. Prevent VILI is the one which is starting to recruit in Michigan and other places. Here they will be using a combination of esophageal manometry to target a PTP of 0, as well as tidal volume titration to try to maintain a driving pressure less than 12. In the years to come, we should see results here. I couldn't find a detailed protocol for the DRIVE trial online. I was looking just last night. Thank you for your attention. I know I said a lot, but please ask questions. Thank you.
One question.
Yes.
All our strategies, as you mentioned, are based on the point time, like this, measure the static compliance at a point in time,
Yeah.
and decide all our strategies. So the question is, how frequently should we doing that point measurement?
Yeah.
And the other thing is, why don't we use a dynamic thing like a dynamic compliance, because it's always lower than static, so it's not going to cause any harm
Yeah.
and why don't we use that value to continuously monitor instead of using a static compliance?
Yeah. So I think for the purposes of clinical trials, it's easier to design them to look at a static component because it's something you can measure specifically. It has a specific definition, and it's less confounded by other things like what is the resistance, what is the flow, how often are you measuring. And the question you asked is very good, is that when we talk about these trials, they suggest that you have a driving pressure and a outcome. And the reality is the driving pressure changes over the days to weeks that somebody is in the ICU. So is that one driving pressure? Is that the average driving pressure? It's not always completely clear. In clinical practice, the dynamic compliance, which you can look at continuously on your ventilator, I think is a very good surrogate for the static compliance, and it doesn't require you having to do an inspiratory pause all the time. Some of the Hamilton newer ventilator claims to give you a static compliance continuously, which doesn't make any sense to me physiologically, because to do a static compliance, you need to do an inspiratory pause. The ventilator claims to have a way of doing it without a pause, which is proprietary and algorithmic. I don't know how to interpret that as well. But I think dynamic compliance is reasonable to follow as long as you have good reason to believe that there is nothing about the resistive part of dynamic compliance that is changing between your measurements. So as long as you're not seeing obvious changes with airway caliber or obvious changes with flow settings on your ventilator, dynamic compliance should be easier. Personally, when I'm at the bedside doing PEEP titration, I do it very simply. I do a recruitment maneuver to some point higher than where I think the patient needs to be, not 60/45. And then I leave them in pressure control with the same delta P, and I drop down the PEEP in increments, and I look for the best tidal volume. Because and by definition, that's the best dynamic compliance. If you have the same pressure, same driving pressure, and you look at the tidal volume, where you optimize the tidal volume is where you optimize compliance. And you don't have to be there with your spreadsheet or your calculator doing calculations at the bedside. You can just look at where was that tidal volume maximized. And I typically have the patient sedated and paralyzed when I'm doing this maneuver to try to take away those other confounders. So I think practically using dynamic compliance makes a lot of sense. I do it myself, but it has not been studied as much in the literature for understandable reasons. How often do you need to do a plateau pressure? What's our standard for ICU measurements, Kelly, at Michigan?
Every 4 hours.
Every 4 hours. That's not the right or wrong answer, but that's a pragmatic answer of like, let's not do this once a day, but let's not do this every 5 minutes either. So, and then you can make adjustments based on, and you can do it more frequently if you feel that you need to, or less frequently if things have been stable for some time.
Thank you.
You're welcome.
I just wanted to say, I thought that was one of the best talks I've ever heard on open